Okay, I think I'll just start. Welcome again to the Saudi and Rise project or virtual learning program where we do a bunch of lectures. And we've been doing it for the last few weeks now. Today we've got the wonderful Professor Treadwell, Marsh Treadwell, who's a professor in pediatrics and division of hematology at the University of California in San Francisco. She's woken up really, really early to deliver the lecture because it's currently like really early in where she is right now. So I'd like to thank her for doing this and let her go ahead. Thank you.
All right, well, thank you so much for having me. And thank you for accommodating the time difference. So today I'm going to talk with you about patient-reported outcomes measurement in sickle cell disease clinical care. The backdrop of this is that major international health policy and regulatory authorities, as well as people with sickle cell disease and their families, have validated the importance of patient-reported outcome assessments to inform clinical decision-making, pharmaceutical labeling claims, product reimbursement, and to influence healthcare policy. So there have been advancements in the measurement of patient-reported outcomes that support how important these assessment tools are, both in clinical trials and clinical practice. So I'd like for you to feel free to chat in questions if you have them throughout my presentation, or just unmute and ask the questions. But I also have some specific time towards the end for a discussion. And I just have one disclosure. So my objectives are to describe the importance of patient and family-centered communication in healthcare, with patient-reported outcomes really as a foundation of patient and family-centered communication. Then I'm going to provide an overview of those measures in sickle cell disease and identify strategies for introducing them routinely into clinical practice. So patient-reported outcomes complement other clinical measures, and they allow tailoring of therapies and interventions. Domains include physical and social functioning, overall health-related quality of life and overall health, symptoms such as pain, ability to complete day-to-day tasks, psychological well-being and mental health symptoms, as well as treatment satisfaction, stigma, medication adherence, and sleep quality. So patient-reported outcomes consist of a series of questions to quantify the level of distress or impairment caused by the patient's symptoms, disease, or treatments. And they can only be reported directly by the patients themselves. They aren't interpreted by any other test or by an observer. The assessment of the patient experience is the first step in value-based healthcare. So routine assessment of patient-reported outcomes in clinical settings has been shown to have several benefits, such as assisting in shared decision-making processes, allowing monitoring and improvement, monitoring improvement or deterioration of health. Patient family-centered communication has shown to improve patient and family satisfaction. And it also enhances trust and thereby improves outcomes as a person is more adherent with their provider's recommendations. So my colleague, Dr. Allison King, and also Kofi Annie, among others, recently reviewed research and best practices related to psychosocial factors in sickle cell disease, and we looked at patient-reported outcomes specifically. So this model builds on previous conceptual models. And so we propose that there are key patient and sickle cell disease related factors that influence these patient-reported outcomes. And then age and gender shifts that shift over time as well influences patient-reported outcomes. So this model is ever evolving. So again, we're looking at how health behaviors impact patient-reported outcomes and vice versa, sickle cell-related complications, particularly pain, sickle cell disease-related factors such as treatments. And this should really be disease-modifying therapies, not just hydroxyurea, but that's what's been most studied. These other factors, social determinants of health, such as education, employment, income, and then finally barriers to care. So there can be barriers related to the system of care that a person is in, or individual barriers that impact their ability to access healthcare. So the studies, there have been a number of studies over the years. First, the cooperative study of sickle cell disease in the 70s, and then later other large cohort studies. And so some of the factors that have consistently been shown to be associated with patient-reported outcomes, female gender has been associated with worse patient-reported outcomes, increasing age, chronic opioid use. Again, mostly hydroxyurea has been studied in terms of disease-modifying therapies, and people who are on hydroxyurea have better patient-reported outcomes, but adherence is important, so those who are actually adherent even have better outcomes. Healthcare utilization, so again, greater healthcare utilization is associated with worse patient-reported outcomes. Pain in particular is a complication that influences these outcomes. Neurocognitive challenges, a few laboratory markers such as anemia, but also if you think about genotype, only one study really consistently shows that hemoglobin SS or S beta 0 is consistently associated with worse health-related quality of life or patient-reported outcomes. So in other words, there's so much variability within individuals, you can't just use genotype, which is the importance of these types of outcomes. And so recently, in a global study using the Sickle Cell World Assessment Survey, or SWAY, the burden of disease was evaluated using patient-reported outcomes, and adults and children and their families really outlined how sickle cell disease created a burden for them in terms of their educational and vocational achievement, among other things. To address the global burden of sickle cell disease and the need for novel therapies, the American Society of Hematology partnered with the U.S. Food and Drug Administration to engage the work of panels of clinicians, investigators, and patients to develop consensus measures for clinical trial endpoints. So although our focus here is on the clinical practice, the clinical trials work really informs that clinical practice, because these panels reviewed all of the literature, met many times over the course of a year to establish what they would recommend in terms of endpoints and measures for patient-reported outcomes. So this particular panel identified, in terms of pain, that you want to look at intensity, as well as interference and impact, and pain behaviors. And so the measures that they recommended, there's a set of measures called the Patient-Reported Outcomes Measurement Information System, and then the Adult Sickle Cell Quality of Life Measurement Information System, which is closely aligned with this PROMIS system. So these are the measures that they recommended. And then in terms of affect, this is an important domain or endpoint for clinical trial, but it does inform clinical practice. And depression, negative emotional impact, was identified as very important, as was fatigue. And so there's a measure called the PEDS-QL for children, again, ASK-Me, and then these PROMIS measures of depression, anxiety. And again, the goal here was to look at what measures could you use for children and what measures could you use for adults. The PROMIS measures go across ages, and then there are separate measures in terms of ASK-Me and PEDS-QL. And then in terms of function, emotional, social, physical, cognitive domains. So there are domains within PROMIS and ASK-Me that measure those. Occupational status is very important. And finally, self-efficacy, or a patient's confidence in their ability to manage their symptoms and condition. I do often get asked, are these measures reliable and valid? And it's important to note that establishing reliability and validity is ongoing. So at any given point in time, the question, is this reliable and valid, is really part of an evolving process. But generally, and I was part of the team that developed the Adult Sickle Cell Quality of Life Measurement Information System. And we started off with a framework. We did a literature review and worked with experts to an expert panel to decide what were the domains that would be important in that measure. Then we got input from people with sickle cell disease and their families and modified our framework based on the feedback. And so from that framework came questions that we asked people about their quality of life or patient-reported outcomes. And those are tested for reliability, validity, and sensitivity using statistical techniques. From there, the content is finalized, scoring, procedures, training manuals. And then over time, we gather data and use that feedback to further the framework development and then maybe start over. And the other point here is that if you want to use these measures cross-culturally, it's important to not just think about translating the measures into a different language, but rather you really need to, you don't need to recreate a measure, but you do need to look at the framework for that cultural context, what's the literature in that particular setting, particularly make sure that the items measure what you think they're measuring by getting patient input. Make sure the constructs really are aligned with that setting from a cross-cultural standpoint. And then from there, you can move on to the reliability, validity, sensitivity testing, content, and so on. So things to consider: measures should accurately show change over time. The item should be important to you as clinicians or providers and to patients and families. And items should be stable enough to reproduce a same score when the health status has not changed, but responsive to detect true change over time. And again, the promise measures that I mentioned, they've been designed to be less culture bound than some of the older patient-reported outcomes, such as the SF-36. So these promise measures also are more easily translated, but these techniques are really based in modern measurement theory, and so are important to use when thinking about using measures, again, across cultures. In thinking about what measure to use and why, it's important to think about, do you want to use a disease-specific measure, such as ASCME or the Adult Sickle Cell Quality of Life Measurement Information System, or the Pediatric Quality of Life Sickle Cell Modules, the PedsQL. And the value of patient-reported outcome, disease-specific patient-reported outcomes measured is, again, their specificity. They allow examination of differences within patients in response to treatments and interventions, so over time. And then differences across sickle cell patient groups are provided by these disease-specific measures. Generic measures provide for understanding the burden of sickle cell disease compared with other populations. So again, the whole suite of promise measures, the SF-36, and the WHO QLL brief. And there are a couple of items in the chat. Let me see. Oh, okay, just that's from Ola. Okay,
Me.
no problem. Whoops. Let's see. I mentioned that the cooperative study of sickle cell disease was really the first study in the 70s that looked at patient-reported outcomes in sickle cell disease. And then there were a couple of other studies in between. And now the largest modern cohort is within the Sickle Cell Disease Implementation Consortium, which was established in 2016. So the Sickle Cell Disease Implementation Consortium established a registry. The consortium consists of 8 sites around the US, and the registry examined factors related to patient-reported outcome for, again, now the largest cohort, contemporary cohort of adults with sickle cell disease. At this time, for this first study that we did, there were 2,200 individuals who were enrolled in this study through the registry, and the age range was 18 years to 45 years. The aim of the first study was just to establish a baseline of evaluation of the patient-reported outcomes within the Sickle Cell Disease Implementation Consortium registry. And what we found was that patients had similar reports compared to to the reference populations on the generic and disease-specific measures, but also there was a lot of variability within the sample. And so most of the patient-reported outcomes were related to one another. And there were also demographic, disease, and treatment characteristics associated with the different patient-reported outcomes and consistent with previous research. So our findings really underscored the importance of considering that variability within the patient population and knowing that it's important to continue to assess repeatedly these patient-reported outcomes, and again, in order to tailor interventions and really be able to improve quality of life and function. So I'm going to go into a little more detail of this second study that we just published, where we looked at the patient-reported outcomes in sickle cell disease within that conceptual model that I mentioned earlier. So again, the first study was really just to establish a baseline of descriptors. What does our population look like in the consortium? And then we just completed this analysis of looking in a conceptual model. So how we did this was we used cut points of the patient-reported outcome measures from the patient-reported outcome measurement information system and the adult sickle cell quality of life measurement information system. So these measures have a midpoint of 50. So that's the average score. And then one standard deviation above for some measures, particularly symptoms, means that the person has worse function. So if your score is between about 55 and 60, then you are considered to have mild symptoms. One standard deviation above 60 to 70, moderate symptoms, and 2 standard deviations is severe symptoms. So, and this applies again to such things as emotional distress or pain. And then in terms of function, the measures are scored in the opposite direction, so that if you're 1 standard deviation below the mean, then that still means worse function. So moderate or severe, again, depending if it's 1 or 2 standard deviations below. And that applies to some of the measures such as cognitive function and fatigue, actually. And we expect that about 20% of the population is going to be more than a standard deviation beyond the mean, so that they have moderate or severe impairment, and that most people are not going to have an impairment in those domains. And what we found was that actually for the adult sickle cell quality of life measurement information system, actually only about 13% ended up having worse emotional impact. Only 15% had worse social functioning. But the other measures behaved as we expected, with 22% having falling in this area of moderate to severe impact of pain, 20% falling into this moderate to severe area in terms of the PROMIS emotional distress, as well as fatigue. And then when we looked even more closely at what factors were associated with what patient-reported outcomes. So the first one we looked at was sleep, and we found that lower income, treatment for depression, pain frequency and severity, these were all associated with more impact to sleep, whereas fewer complications was protective, so that fewer complications was related to better sleep. In terms of pain, not surprisingly, frequency and severity contributed to greater pain impact. But also we found that employment status, so those who reported they were disabled or had some other employment status, had a greater pain impact. And then for cognitive functioning, we found that lower income again, treatment for depression, and pain frequency were associated with greater impairments in cognitive functioning, and that fewer barriers to care was protective, so that people who had fewer barriers to care had better functioning. So even though we're calling these predictors, it's really an association, because all the variables were entered into the model at the same time. So it's not really that this is a predictor, it's just highly associated. And then in terms of emotional distress, income again was really important, treatment for depression, pain frequency. So we're seeing some consistent variables across the patient-reported outcomes, with again lower complications being protective in relationship to emotional distress. For social functioning, disabled, employment status, depression, pain frequency, severity, and the protective effect of fewer barriers. And then lastly, male gender was protective against fatigue, fewer barriers, protective against fatigue as well. And then depression and pain contributed or highly related to more issues with fatigue and tiredness. So from a clinical standpoint, the questions to ask yourself about these patient-reported outcomes is, why is it important to measure this construct in my clinic? And you want to, again, think about what are the characteristics of your population. So for example, in the adult sickle cell quality of life measurement system, we found a variable, or one of our measures is called stiffness. And for the older patient, that was very important. For the younger patients, 18, early 20s, that measure was not that important, but it was very highly endorsed as important by the older patients. You want to think about, what's the evidence that's accumulated for this measure with the sickle cell population, and everything that I've mentioned so far does have some good psychometric evidence for the populations. And then think about the different assessment strategies. You can use computer adaptive testing, and what that means is that if you have access to a tablet or computer, that a person responds to an item, and then the next item that comes up depends on what they responded to the first item. So if they don't have fatigue, then there won't be further questions about fatigue, for example. Or if they haven't had pain within the last year, then they won't be getting a list of questions about pain. So that's how computer adaptive testing works. Short forms were pulled from those computer adaptive testing banks, and usually consist of 4 to 8 items. And the newer measures do provide for even using a single item to measure a construct, and still retain some precision in measurement. So in thinking about what strategy you want to use, then you want to think about, what do you have available? Do you have computer adaptive testing available? Do you have a number of things you want to ask? So you only don't want to use a lot of items from many different forms, maybe just single items from those forms. Having a measure that's easy to use and score for both patients and clinicians is important. And really recognizing if the measure supports the patient goals. So if you want to decide to use a cognitive functioning measure in thinking about people's goals related to vocational achievement or educational achievement, then you would select certain measures. And it does help to have measures that can be used across the pediatric and adult populations. And then, as I mentioned, how appropriate is this measure cross-culturally in terms of the items and the constructs that you're measuring. Some of you may be familiar with a number of measures that have been around for a while, such as the Beck Depression Inventory, the PHQ or Patient Health Questionnaire, and the Center for Epidemiology Studies for depression. So these are older depression measures, and then you have the PROMIS measure of anxiety and depression. And so there has been cross talk and published on this website called Rosetta Stone that looks at how you can compare these the PROMIS newer measures with these older measures, so that you don't have to abandon your older measures, but that you can begin to transition perhaps to the newer measures and know that what score on the Beck or what score on the PHQ-9 or the CESD corresponds with these scores, the mild, moderate, or severe impairment on the PROMIS, and how that corresponds with these scores on the different older measures. Electronic health records do now often include the functionality to collect patient-reported outcomes and integrate that patient-reported outcome data into the patient's chart and into your conversation with the patient and family. And the one thing I didn't mention is that besides pediatric, adult measures, generic, disease specific, there also are proxy measures that a parent or caregiver can complete for a child. It's been shown that those measures are not, don't have a one-to-one correspondence. So as a child gets older, it's important to have both a parent do the proxy measure as well as a child report on their own. So people have found, or practices have found, that they might be able to collect the patient-reported outcome data prior to the person coming into the clinical setting. So perhaps as they're waiting, using a paper and pencil or on a tablet, or through their patient portal. It's important to collect the data real time and not just collect it and not actually discuss it with the patient. Research has shown over and over that incorporating this data into the clinical setting does not increase the length of the visit. You do have to structure the visit a little bit differently, but if the measure is completed before the person comes into the room and you take a look at it and then discuss it with the patient, then that actually improves outcomes by informing clinical decision making, but not in increasing the length of the clinical session. And then it's also important to think about what domains really are most closely influential on one another. So in sickle cell disease, it does look clear that pain should always be assessed. But when you're thinking about cognitive function, for example, that's highly influenced by emotional distress, depression, anxiety. So cognitive function shouldn't be measured by itself. It should be measured in collaboration or coordination with measuring what's the person's affect. And so for talking further about patient-reported outcome measurement within the electronic health record, or that a person can complete from their cell phone or from a tablet, it's much more accurate, complete, high quality, and of course timely. It's instantaneous. And if the person is a part of a research study, then they can be getting reminders about completing the electronic PROs. Monitoring can be real time in terms of deterioration or improvement. And then you don't have as much challenge with recall bias. And as you move from a paper and pencil measure to a secondary data entry, then that's prone to error. But a direct completion by the patient of the within the electronic health record through their patient portal does minimize those errors. And this does make it easier to do the computer adaptive testing. Again, there are skip patterns where if the person, let's say, again, didn't have pain or says they have a low level of fatigue, then they don't get the next questions. So then you can just, the patient doesn't have to figure out, oh, I should skip to the next item. They're just able to move on to probably the next domain or construct. And so electronic administration of these measures is less burdensome in terms of cost as well as personnel time. So that I wanted to leave plenty of time for discussion. So wanted to ask you, how do you foresee integrating patient-reported outcome measures into your clinical practice? Are you already using these measures? What are you using? What's working best? So I'd like to open that up for discussion.
remember, or you can also put the comments in the chat box in the bottom if required.
So what measures are you all currently using? Do you use the PHQ-9? Is there SF-36? Do you use the PROMIS measures? And you can chat in. And you can say none of these.
It says we don't have one in the chat box.
Okay. Anyone else?
Again, we don't have in our center as well.
Okay. Do you, so a patient-reported outcome doesn't have to be a measure necessarily, but using a measure can be helpful for a number of reasons, and we'll get to that in a moment. So are you asking the questions about how much pain has a person had? How much is it impacting their functioning, for example? Do you feel depressed? What is your mood? Do you feel anxious? So are you asking those questions? So I'll look for answers in the chat. So the question was, are you inquiring about experience of pain, experience or mood problems? And so one is saying not to all patients. And there's a general evaluation, and it's not a system. Any other responses to inquiries about pain, mood? So social impact is, again, it is very important. And again, this measurement is done periodically. So I think that's where this kind of discussion is important, because there is so much value that's been shown to using these types of measures. And yet they do have to be thought about by clinicians and by the patients and families. So what do you think would happen if you just asked the patient and family, how much pain did you have since I saw you last, and how much did that affect your ability to do what you wanted to do? What would that be like for you?
Yes.
It would be good.
Yes, hello.
Yes, I can hear you.
Yes. Thank you. I think the problem for us in our hospital, we are having this schedule that we are asking them how much pain you have. And there is also for us one special form for that. But the problem is our center, it is not that much prepared for all this thing. That's why we are having this problem. But anyway, in our ER or in our ER and in our clinic, we are asking patients if they have pain, how much the pain you are having. So we can prescribe for them the type of the medication or type of if they need support. Most of our patients, they need support, social support. It helps. Sometimes it will help. Most of the patients, they are not asking for the medication. If they will ask for the support, we are trying our best for them. But it will help for them if we will ask them for that.
Yeah, well, thank you very much. That's extremely helpful. So I think that it can be daunting when you hear about all of these measures, you know, the patient-reported outcome measurement system or the electronic way to administer it, and you realize that you are actually asking. And so my point is not so much that you it will be good at eventually to use these measures, but for now to just think about systematically asking these questions, because as you pointed out, it really is the pain doesn't exist by itself, and that's what our studies showed. The pain is really related to employment, depression, inability to manage day to day. So there's a whole psychological, social aspect of pain, and and so it's important to ask not just about the pain, you know, how intense is it, how often have you had it, but then how are these other things affected, again, social, employment, and so on. So school. So what my suggestion would be that that the step really would be to be systematic in asking. And another reason to be systematic in what is asked is because then resources can be set up, you know, again, more consistently. So when we found how much employment was related to the patient-reported outcomes in our study, then that really helped us to think about focusing a lot on that. I mean, we're psychologists and we've done a lot of this work. So we knew that, you know, mood, there's a need for mental health services, but we weren't as aware of how much people's employment and schooling was affected. And so by asking everyone those questions, then it really can help in setting up resources.
One point, Mom, another point, please. That in the clinic for us, okay, it is, we cannot take a long time with the patients. So if a special center for them and a special clinic for this thing, it is, I think it's much better, because 25 patients with the 3 or 4 hours, it is not enough for one patient. We will be in a hurry to finish with them as soon as possible, to finish most of our patients. But even though in our clinic, we are trying, my doctors and me are trying to help the patient, as to leave the patient to feel comfortable more and to be as the other people, without the pain. This is our aim, that to let the patient not to feel the pain, to be more comfortable. I mean,
yeah,
even with everything, yani.
Mm-hmm. That is a really excellent point, that you're in an acute setting and the patient's comfort is your immediate goal. And that is important. And so in the acute setting, it is important to assess the patient, listen to the patient, and treat the patient quickly. Once the patient is comfortable, or as they're beginning to be ready to be discharged, let's say from an emergency setting, then you can ask some of these other questions, because the importance of emotional distress, for example, in relationship to pain is immense. So it's just really consistent across all studies around the world that the prevalence of depression in people with sickle cell disease is really quite high. It's on the order of 25% to 50% of a population that's been studied. And so it's important to treat that pain, as you said, get the person comfortable. But as you're getting ready for them to depart, then you can ask, what's the impact of this pain on your mood? And so I did give you a lot in terms of all of these patient-reported outcomes. But I think that given that you're letting me know that you don't have this embedded in your electronic health record, that you don't have these measures available right now, that you can start and think about where to start. Pain is the first place to start. So I'll just say that you're already using a patient-reported outcome because pain is what you're asking about. And that's fundamental to sickle cell disease. But next, I would really add mood. I would add depression, anxiety. And now, again, in different settings and cultures, depression and anxiety may be hard for people to talk about, but it is so hand in hand with pain, related to both opioid use, related to the pain itself, related to how the pain interferes with the person's functioning, that it's important to ask. And it's important to let the patient know that it's just something that can happen when they have sickle cell disease, and that there are resources or things that can be done to help. So I'll stop there and hear what people think about asking. Well, again, someone here does say, oh no, it's not physiological. What do you think about the psychological, the emotional part of sickle cell? Do you think it's worth asking in the acute setting once the person is comfortable, or even in the setting that's more not acute? So what do people think about the importance of asking about psychological, social, emotional?
Yes, can I share?
Yes.
I believe when the patient are comfortable emotionally and social, they will be forgetting the pain. And I think the social when they are feel uh, eco-social also, when they are feel happy and really comfortable with that, that's really big help. Even when they are giving you all data, when the brain is only thinking, for the example, the social, eco-social, or they have a problem with the emotion, even the data will not be clear or not specify what we needed exactly. Yeah.
Thank you very much. That is absolutely ideal, and it is what again, all of the data has shown, that it's so important to ask about emotional, social, psychological functioning. And as I said, I think one of the biggest fears that providers can have is that they have so many patients and that it will be too difficult to ask about these things. But it's just been shown that it doesn't add to the visit if you structure the visit in a particular kind of way. And then further, it really helps the relationship between the provider and the patient. So in the end, it really makes the relationship easier, and they are more going to be listening to what you're saying if they feel that you're listening to them. And so a way to start that is to really ask, when the person comes in, what is important to you? And I think, and you're already doing that with pain, saying, what is important to you? And the person is saying, relief from this pain is important to me right now. And if, as you create that trust and treatment of the pain, then you can ask what you think might be important. The patient says, this pain is important to me. And then you can say, all right, then now that we've gotten it under control, many people find that when they have a lot of pain, that they get depressed. How is that for you? What is your experience with that? So I see in the chat, is there a brief set of patient-reported outcomes that can be completed while the patient is waiting that can be facilitated by a nurse or healthcare social worker? And that answer is absolutely yes. And so what I would recommend is at this stage of where it's not being asked systematically, in order to move forward, to begin to ask it systematically, is starting with pain. How frequent is it? How severe is it? How much does it interfere with your daily life? And then ask, what is your mood? And is it high or low? So I can provide a brief set of questions that seems like they may be the best ones to ask here: pain, mood. And then the last one, the last set of questions, well, I would ask as well about sleep and fatigue, because those have been shown as well over and over to be very important in sickle cell disease. And then perhaps the nurse or healthcare support worker can ask about these other social determinants of health, employment, housing, resources, and those kinds of things. So yeah, I can provide a set of questions that I think could be helpful to ask, and would just encourage the use not only for that individual relationship with the patient and the family, but also because it can help if many people in your setting have the same concern, let's say about employment or school, then that would help in your clinic to try to get more services or resources or support for that particular issue. So if you ask everyone the same question, then you'll begin to know what's the need in your community. So I went through a lot and left a lot of time for discussion. So I want to see if anyone has any particular questions about actually what I presented. And so please let me know if any particular question came up. Does someone have a question or comment?
I can't see any more comments or questions. Oh, and there's a question here actually. What do you think about what is the plan to manage your pain? More about to ask what is your way that you suggest the healthcare setting to do for you during pain time?
I think the question is is the question about managing acute pain? Or is the question asking the patient about how they manage their pain? And maybe, again, I'm just trying to clarify what the comment is. Perhaps
I think, this is Baba. I think I would really appreciate if that person speaks up, because they're going to say more. Because I don't know whether they're talking about maybe alternative pain management, or what I think they might, what's the name of the person again? Ola?
I think it's WADA.
Wada, yeah, Wada, do you want to please say what you're referring to? Are you looking at the psychological management? Are you looking at alternative management, or what is your question directed at? And I think it's very, very helpful to do that, because I was going to ask a question in a similar way, but I want to hear your comment first. Wada, please. Wada, can you unmute yourself? I don't know whether the person, is it the person
I
having
think they, well, they did clarify in the chat. I think that they're asking the patient, how do you manage your pain? So that that's a very good question, and it's very important. And so that it's a great question, and it helps you to build on that pain management. So the thing about the question is that we are learning, we're learning over time that management by medication only, you know, has a lot of side effects. So it's important to talk to patients about what they do to manage their patient in addition to medication. And everyone does something. They either rest, they drink a lot of fluids, they might meditate. It's important to ask them about when they have pain, what do they think? And the reason why that's so important is there's a concept called self-efficacy, which means which really talks about how a person, if they're very anxious, fearful, I can't manage, that actually leads to more pain. But patients who have more confidence, they have much less pain. So so the psychological is very important. So what people say to themselves about their pain is very important. So yes, this is a really good question to ask. And as has been pointed out, the idea is in the acute setting to take care of the patient's pain, get it under control, but then use that time to sort out how are they managing, what could they learn to use to manage even better. And Baba, did you have a question?
Yes, so I don't know how much, I don't know whether what is their own comment about their setting. Do they have psychology on their team? Do they have, who are the other key professionals that they find useful in dealing with some of helping them to understand patient-related outcomes in their setting? I'm sure some of them might try to.
So who are other members of your healthcare team? Yeah. Physicians, nurses, but do you also have a psychologist, someone who asks about income, housing, food?
Yes, Mom.
Yes.
Shall I have this compound? But I have one point for us in our hospital. Actually, I'm working in hematology clinic before. For our patient, if we are talking with them, asking them about everything, if we will feel that patient, he has any psychological problem, we will ask the patient, shall we shift you, or I mean, refer you to the psychological clinic? If you, do you feel that you need, if he will say yes, that will refer him. And we will follow what patient he feel. Sometimes patient, they will not agree to go to psychological clinic. So we are trying for the doctor and the nurses there, they are trying them, yani, they are working hard for this point. If the patient, he need to talk with the doctor, only he have any problem and he want somebody to share the problem with him, to help them. Sometimes if we cannot, if the patient he refused to go to psychological clinic, we are trying our best to help the patient. Actually are doing this one, me and my doctor Said, in our clinic. We are doing this one. And we are getting really good results with some patients. It is really helpful for the patient.
Very good. Yes, it is. It is very helpful. And this thing about, the patient reported outcomes and the patient-centered care is that sometimes you have to, as the provider, continue to work with the person before they're ready to move on to in-depth work with a psychologist on their concerns. So it's great that you have psychologists that you can refer people to. And sometimes it can just take time to get the patient and family to agree to that. But if you bring it up often and early, before they have very many symptoms, that can help them understand that it really, people have different health beliefs, which is another thing to think about. So as you have these dialogues with patients, you can begin to understand what is their belief about what's happening. And if you let them know that what's shown is that pain and anxiety and depressed moods can all come together, then they can have a sense that it's just something that they can get some extra help for, or get some help for, without feeling that there's something very stigmatizing about it, or in some health beliefs, that people feel it's a weakness. And so if you just bring it up as just a natural part of this disease and the impact of this disease, a person may not believe that at first, but over time they will get there.
Thank you. So thank you. This is okay. Sorry, Atiga, you can speak. I just.
Yes. This is
You wanted to say something?
Yeah, I want to add that the nurse or the doctor, if they will be friendly with the patient, I think it will help for the patient will, and the family, they will feel more comfortable. They will be friendly with you. And
yeah, absolutely. Absolutely.
This is my point, and this is my aim. Actually, if I'm going to my work, this is my aim, really, to be friendly more with the patient will be more comfortable with me. So if they have any problem, I can help them. We can help them. We can do anything for them. We are doing our best. It's really helpful for them. This is what I want to add. Thank you.
Yeah, no, absolutely. And, again, I showed you models and measures, but it really comes down to what you just said. It's really about talking and listening to things that aren't just about sickle cell, but listening to what's happening at school, what's happening at home. And yes, that friendly demeanor goes very far.
So one of the things that we also found very helpful is that some patients have this, they have belief that when you refer them to the psychologist, either is a weakness or an indication that their family setup isn't strong enough to support them. And so to discourage that or to help them to integrate, we therefore make psychology as part of our team, so that when we start the clinic discussion, we have the psychology and we introduce them to the psychology, and we say that this is part of finding how you're dealing and coping with the condition. Yes, I think I understand what you also saying about being friendly to the patient, but I also know some limitations. So, for example, like I had a patient and I was talking to them, and I didn't realize that there was a very simple problem that the child didn't tell me or the nurse, but they then had time with the psychologist and then said to the psychologist the reason that he didn't want to start on hydroxyurea was because he read somewhere it says importance. I mean, so it's because somebody had really kind of had more time and just really given them opportunities to talk, and that they were able to actually kind of reveal some of the in fact, another one had to come with so many pain episodes, and in Sierra Leone they had this crisis. They were separated, some of them to the US, some of them to the UK. We had no idea that her mother was in the US, and that was the reason why she was coming with repeated pain. When they were then united, then that is how the pain just really seemed to have resolved. So I think if they can help the service to recognize that we have different skills and
Right. Mm-hmm.
we're limited in what we can do as our own specialism.
Yeah, and again, that's so important to say, you know, what is important to you about this? So as the physician, you're thinking you have, you know, all of this pain, so you should go on hydroxyurea, but the patient is worried about impotence. And so if you didn't listen to that, they're saying over and over and over that they don't want the medicine, even though they're having so much pain. So a different question, you know, what's important to you? And what do you want in terms of your life goals, and then that might come out sooner. All right, so we're over time. Thank you all for the discussion, and we'll be meeting again next week. And so I'll be sure to leave plenty of time for discussion. If you have questions from this one, let me know, and I'll be ready to answer.
Of course, there's a Slido chat, a Slido page where you can put questions in there as well. If you have questions from this lecture and you want to bring up in the next one, that's absolutely fine. You can do that as well. But yes, thank you so much for this lecture. It was very insightful and very important to understand the importance of emotions and how that ties in with pain and how people are dealing with it. And I think everyone found it very insightful as well. So with that, I think we close this meeting, we'll close this session, and we'll see you again next week, of course. And for everyone else, have a good day. Thank you so much.
Thank
Bye
you.
all.
Bye.
Thank you.
Thank you, bye.
Thank you for all.
Thank you.